Good morning, everyone. So Michael Duncan's going to give us a kickoff on this. Michael is our Behavioral Health Services Director.
Morning. Good morning. Good to see everyone. Today, I'm pleased to introduce Dr. Bevan Croft. She is the Director of Behavioral Health at the Human Services Research Institute, or HSRI, a nationally recognized organization that spent over 50 years partnering with states and local communities to strengthen behavioral health systems through research, planning, and data-driven decision-making. So we're very excited to present this data to you today with the needs gap analysis. It's a culmination of a snapshot over the last several months of individuals from the community, whether it be providers, participants, or county workers. And so with that, I will ask Dr. Bevan Croft to come up and present the data.
She's coming up. I just want to mention the purpose of doing this. Sorry, I know when you hear the voice, it's hard to see where it's coming from. The purpose in doing this really was driven initially because it is a required component of our opioid settlement work and strategic planning. But as we were doing it, we were like, geez, why don't we just go ahead, because we're going to have all the right people in the room, and include mental health and intellectual and developmental disability groups as well.
Hello, good morning, Commissioners. Chairman Martin, thank you for having me here. I am Dr. Bevan Croft, and I'm with the Human Services Research Institute. I flew down from the Boston area yesterday, very easy flight into the wonderful Greensboro Airport. So I prepared a presentation that's really meant to be an overview of the report, which is more lengthy. It's about 70-some pages with appendices. But what I've prepared for you this morning is a brief overview of the project, our sources and methods. I'll spend a little bit of time on some key overarching findings, but most importantly, I want to spend time on the recommendations, the what next, and sprinkled throughout each of the recommendations are more findings. So we really tried to integrate most of the findings right into the recommendations for you, so you can sort of begin to think about why we're recommending what we're recommending and what could happen next. Michael shared a bit about HSRI. We're a nonprofit. This is our 50-year anniversary this year. I've been with HSRI for almost 20 years, and I direct our behavioral health work. We also have a team that works specifically with intellectual developmental disability systems, which we were able to collaborate with for this project. We work with states and counties throughout the country. We also have some federal projects, and all of our work is focused around using data and engaging with communities to make informed decisions about policy. So this was a behavioral health system study, a gap analysis. So what do we mean by behavioral health system? It is a term of art, but the way that we at HSRI think about behavioral health systems is the entire constellation of practices and programs and people that promote well-being in the community across the entire population. So that includes preventing mental health and substance use problems from happening in the first place by promoting wellness across the population, all the way through to providing evidence-based clinical treatment for people with diagnosed mental health and substance use problems. And the idea is all of these programs sort of work in concert with one another in a holistic way to most efficiently meet the needs of the population. Our project aims were to first just look at the prevalence of mental health, substance use, and intellectual and developmental disability related needs within the Forsyth County community. To look at the assets and the resources that are already available in the community, of which there are many. To identify where is the gap between what the community has and what the community needs, and then make recommendations to close that gap. Our hope is that these recommendations can really serve as a roadmap, can really be leveraged and picked up right away to support strategic planning in the future. And I believe that's what Behavioral Health Services intends to do. So our method, we used a mix of qualitative and quantitative methods for this study. On the qualitative side, we conducted 4 listening sessions completely open to the public, 2 in person, 2 virtual at different times of the day, to really try to just invite anyone who's interested to participate. And then we also conducted a series of interviews and focus groups across the community with specific groups that have expertise in the system, including and especially people with direct lived experience as people with mental health and substance use related challenges, people and families with intellectual developmental disability, to really get that lived experience perspective, which at the end of the day is sort of the most important. We also analyzed quantitative data from a range of sources. There are a lot of publicly available data that we availed ourselves of to understand prevalence and different community characteristics. Partners Health Management also shared utilization data for the Medicaid population that they serve, and we consulted some other North Carolina-specific data dashboards. We also, because we never like to reinvent any wheels, we did a review of past reports, various other documents related to the behavioral health system, just to make sure that we're building on existing knowledge. This is a list of the organizations that supported us, participating in interviews and focus groups, and also helping us to recruit people with lived experience to speak with. We asked everybody we spoke with about some very basic demographic characteristics, just to see if we're getting a representative group of folks. Women were overrepresented in the people that we spoke with. However, when it comes to race and ethnicity, we actually managed to speak with a relatively representative proportion. These numbers are similar to the proportion of the Forsyth County population. So just as a snapshot of our biggest picture key findings, first and foremost, Forsyth County behavioral health system really has some strong networks and is quite robust in terms of the numbers of community partners and their relationships with each other, working together for many years on shared goals. So that was really a key strength that we observed in this community. A lot of the challenges, the real pain points in this system are not unique to Forsyth County. They are challenges that are faced throughout this entire country, related to workforce capacity, access to care. We know from a lot of research and just practical knowledge that social drivers of health, things like poverty, food security, access to transportation, access to a safe and stable place to live, those have enormous bearing on a person's mental health and on a person's ability to cope with substance use problems. And so these showed up again and again in the conversations that we had and in the data that we looked at. And a reliance on crisis services. So behavioral health systems, in many ways, the way that they're designed, are not always set up to support robust prevention. We end up intervening often when people are at a crisis point. So we observe that in this community, and again, not unique to this community. We all have seen the opioid overdose data and the steep increase in opioid deaths in this county. Since 2022, 2023, the rates have sharply declined, which is amazing, and I think is a credit to a lot of the efforts in this community. But there's still more work to do. We also noted, and I'll share a figure on this later, that Forsyth County has, when you compare it to the other largest counties in North Carolina, has higher rates of emergency department use, suggesting that that reliance on crisis services is particularly important here. We observed significant racial and ethnic disparities in social drivers of health, and then in some access to care measures, which I'll talk about. In terms of intellectual and developmental disability, statewide, there's a very large wait list for the home and community-based services for this population. We observe that that's a major pain point in this community as well, and that particularly people with co-occurring mental health problems and intellectual developmental disability are experiencing barriers to care. Just a couple of graphs for you before I get into the recommendations. As I mentioned, social drivers of health are just incredibly linked to well-being. And we observed that in this community, Hispanic, Latino, and Black and African American communities are experiencing much higher proportion of poverty compared to the overall population. And this is just something that's really important to keep in mind as a contextual factor behind a lot of the other data. When it comes to prevalence of mental health and substance use issues, there are a lot of indicators. There's a source called County Health Rankings that allows you to look at your community compared to other communities and the state. And we really found that Forsyth County is similar to the rest of the state of North Carolina in a lot of measures for adults and youth statewide. In terms of the overdose deaths that I mentioned, the story is very clear. Obviously, the opioid epidemic resulted in this, and COVID resulted in a steep increase in overdose deaths. This graph here is the rate per 100,000 population. The dark blue line is Forsyth County. The light blue line is the state of North Carolina. There's been a precipitous decrease, but still the levels are higher than before the opioid epidemic. And the 2025 projections, which are the latest data that we have, show that Forsyth County is a little higher than the state average. So it's gone down, but not down enough. And then in terms of emergency department visits, this graph shows Forsyth County, which is the second grouping next to the four other largest counties in North Carolina. And when we compare them, we see that Forsyth County has the highest rate of emergency department visits for depression and for suicidal ideation, and the second highest rate, second to Guilford County, for anxiety. And I added a quote here from a person with lived experience that we spoke with. A recurring theme was really that people would go to the emergency room seeking support and then not getting it or not feeling that they got it, and then just kind of being told we'll come back again if you need to. So we've organized our recommendations into 3 tiers, recognizing that the behavioral health system is complex. There are local, regional, and state leaders in the system, and behavioral health services within the county, has its own locus of control. So we organized our recommendations into 3 tiers. The first tier are actions that we believe behavioral health services could lead with a modest investment in time and resources. So these are things that could be done more in the short term and are more directly within the purview of Behavioral Health Services Division. The second tier of recommendations are actions that behavioral health services would have a significant role in, but that it would need to take in close partnerships with other entities in the county or the state, Partners Health Management, other providers, the state, et cetera. And finally, we offer a few Tier 3 recommendations that are much larger, much more complex, that would require leadership from entities outside of the county with behavioral health services as a key partner. We included these recommendations because they really reflect, I think, some of the most significant issues, and we want to sort of name them and put them out there so that the county can be ready to be a strong partner when opportunities arise. So for the Tier 1 recommendations, I believe I have 6 or 7. The first is related to information. In the listening session, a phrase that someone said, and it kind of kept repeating around the room, was Forsyth County is resource-rich and explanation-poor. We heard a lot from people with lived experience, from family members, and from providers that a lot of folks just don't know what they're eligible for. They don't know what's out there. And what's interesting is we heard a lot of people saying, I wish there was a single sheet of paper or a one-stop shop where you could just go and find out information about services. And in fact, there are such sheets of information about services. They exist out there, but they're not necessarily getting into the hands of people who need them in a timely fashion. We think that, it's not necessarily that the information is not out there, but that the information pathways aren't strong enough, and that there needs to be more of a kind of a coordinated strategy for informing the public about services. So we have a recommendation to kind of really inventory where are the information assets, and then how can that information be streamlined, be more accessible, be more user-friendly, and more out into the mainstream.
Can I interrupt you?
Yes, please.
Could you, just right here at this point, could you describe sort of a better way in a place that's doing it well, doing the communicating with others, people knowing more about the services they're eligible for, and the mechanism and tools that they're using? And maybe you come up with more of that, but it just seems, I'd like to know what does it look like?
Yeah. So I will say it's an issue that it's not easy. It's actually quite challenging. So a lot of communities struggle with. In Wake County, which is another jurisdiction that we've worked with in the past, there's sort of an interactive website that they've begun to build where you can sort of say, you know, I am a parent of a 16-year-old looking for help with anxiety, and you can kind of sort of type in, you know, who you are and what you're looking for, and you can kind of have more of a searchable format. So there are ways to leverage technology to be able to kind of have searchable databases or provider directories as opposed to like a static sheet of information with phone numbers. But I think a larger strategy that we would recommend is actually more grassroots, more boots on the ground, and really kind of continuing to do what Behavioral Health Services and Partners is doing, but maybe put some more resources into it, which is showing up at community events, showing up at community groups, you know, really disseminating information to the trusted folks in communities, partnering more with faith communities to ask them to disseminate materials, things like that. So it's there isn't a single shot, I think, intervention here. It's really more about developing a communication strategy.
Yeah, my observation is that at all sorts of events, you know, that where the public gathers, we have all manner of booths from the county to other agencies. I mean, I feel like there's a lot of that. The issue is, how do you get the people at those events? Yeah. Particularly people who need to talk to folks. Mm-hmm. And that challenge, if somebody's got to figure out a way to do how that happens, and you talk about grassroots networks, so I do think faith community can be very strong.
Absolutely.
And I think we have a strong faith community, and I mean, our number of churches per whatever unit you want to compare, we have a lot. And maybe maybe we're not doing, from my standpoint, maybe we're not doing as good a job there. But there's got to be a way to get people to the events where they can learn these things.
Absolutely.
But I know there's not a magic bullet, but I got an interactive website and faith community, but it's, if you know more, that'd be great, but I won't delay.
Absolutely.
I would like to just kind of supplement what Chair Martin is saying as it relates to the outreach component. I think that idealistic when we have these fairs, people come out and we can share our information, but let's be realistic. We have our kids and all of this other stuff is going on. So what am I actually absorbing to really go into my healthcare provider and talk intelligently? Not much, right? I just came out and they gave me some flyers and said some things that I don't even remember. So I think that although that is a way to initiate conversations, how do we build the discussion so that our citizens become intelligent about what's going on with healthcare? And I think that we have underutilized our faith-based community in this community where it is very strong, particularly with the Ministers' Conference. That is more of an ecumenical representation of the different faiths in our community, not only across religion, but across race and sex and all of that. So I think that trying to figure out the partnerships with organizations that represent people that have their attention at certain times could be more beneficial for us.
Absolutely. And honestly, I think that this is one of the most low-hanging fruit recommendations that we have to offer. I think that there's tremendous opportunity, and there are already some good relationships, so it's really a connecting the dots kind of thing.
Thank you.
Yes. So one of the more striking data points that we observed was that Black populations are overrepresented in terms of folks having substance use problems, and actually overrepresented when you look at across substance use outpatient treatment. 50% of people who receive substance abuse intensive outpatient treatment are Black in the community. However, when you look at medication-assisted treatment particularly, the statistic that we have here is for methadone, you see that Black people comprise only 12% of folks receiving medication-assisted treatment, which is one of the most important evidence-based practices to treat substance use disorder. So something there is a disparity here, it's very clear. So we do recommend that, and Latino residents also are underrepresented relative to the population in substance use disorder, in all forms of substance use disorder treatment. So we recommend that there be a close look at the current outreach, education, information, and practices to really understand what is behind this disparity and how can services be tailored to be more culturally responsive to these communities. And I have some more recommendations related to medication-assisted treatment further on.
May I ask, is there a disparate problem with hesitancy to use medication treatment?
You know, it's not something that we picked up in our listening sessions, focus groups, and interviews, but you know, the scope of this study really wasn't one that enabled us to have, you know, a focus group with a group of Black men with substance use problems in the community. And that is actually what we recommend as a next step, is to really dig into that and seek to understand, maybe also speak with families, with faith communities, with other, you know, with leaders in the Black community and the Hispanic community to understand what's underneath this number.
Oh, so I would just add that I think there's a book that looks at the disparity health-wise. It's called Medical Apartheid. And so I think because of the historical context of what has happened in the past and what we see here as it relates to treating Black Americans fairly in this space around proper health care, we're seeing the residuals. So although I think that now we are much more cognizant of making sure we treat everybody fairly, the residuals of what has happened in the past continue to plague us now. And so where we see that obviously Black citizens need treatment, they're not getting them for, you know, I can't imagine, for so many different reasons. And I think that that is a major concern for our county, particularly as it relates to the representation citizenship-wise here in Forsyth County. And I would be absolutely interested to know maybe what other counties are doing to close that gap.
Yeah, absolutely. And what's particularly interesting to me is it's not that Black folks aren't participating in treatment. It's that they're not receiving this specific evidence-based treatment. And so really that's, I think, an important question to hone in on.
I would suggest that one of the sub-questions needs to be whether there's a sort of an experience-based conviction that the availability of a medication in the long run is unreliable.
Yeah,
Particularly particularly in an environment where the rules on eligibility for all assistance programs are changing rapidly and usually for the worse. So.
Yeah, and we'll put a pin in this a bit because we do have another, I think, potentially related recommendation in Tier 2. Another strong theme in our study was related to peer support. So peer support is a model, it's a professional discipline that's really grown exponentially in the past 20 years in the behavioral health space, where folks with lived experience of mental health problems, of substance use problems, who are themselves in recovery or continuing to live with those problems, but kind of managing them day to day, are trained and certified to provide mutual support, holistic support in the community to people currently struggling with those same problems. There's been a lot of research on peer support. It is an evidence-based practice. It is a way to expand the behavioral health workforce because you're bringing in people who may not have the higher levels of education or the licensing and credentials who can still provide wraparound support. And it's culturally responsive as well because people are, the workforce is coming directly from the community. So there is peer support in the county. In the little bar chart here, you'll see that year over year, the numbers of people receiving peer support services in Forsyth County have increased in the Medicaid data. However, we heard from and observed from a number of interviews that there are opportunities to expand peer support. One thing about peer support is that for it really to work, particularly peer support that's delivered within like an outpatient clinic setting, it's really important that the peers have the supervision and the opportunity to sort of deliver their practice in a way that's consistent with their training. And sometimes when it's when in a clinic model where there's a lot of clinicians, they may not understand, kind of the role of peer support or how it's particularly delivered. So we recommend that there could be some opportunities for some. Honestly, it could be relatively light touch technical assistance to facilitate expanded peer support across the behavioral health system. There's a strong peer-run organization called Green Tree here in the county. In a lot of counties we work with, there are multiple peer-run organizations providing all different kinds of services. So there may be opportunities as well to foster more peer-run organizations to provide that kind of grassroots wraparound peer support that really works for some people, including folks who are kind of harder to engage in with other services.
Did you interview anyone who's a part of Stepping Up?
We did not interview Stepping Up directly, but we're aware of the program.
Well,
yes, and that's one of the assets.
You should have interviewed that group.
Yeah, we've heard some good things about the program and it being really important.
Commissioner Wisenhunt, to that point, I just want to point out that this is peer support, I believe, that is billed through Partners Health Management. It's not necessarily representative of all the peer support that's happening in our community. Right. And the other thing we probably should have mentioned before is when you see Forsyth County in this context, it's talking about our whole geographic footprint, not necessarily the county, the entity.
Because just to clarify, we do not provide services. And so this really is an assessment of the entire county, the community. A lot of these findings will be takeaways for us to share with Novant and Atrium and Daymark and a lot of the providers. And so I just want to clarify that we don't provide services. It's not necessarily anything that we are or are not doing, but we certainly want to be a part of the solutions for our community.
Oh, okay. Okay, we actually did speak with Stepping Up. I was just reminded. Yeah, absolutely. And this recommendation isn't necessarily that the county should provide more peer support, but it's that the county could have a role, and other jurisdictions we work with, counties and states, have a role in offering some technical assistance, again, helping to connect dots, helping to kind of keep the conversation going so that providers can be better prepared to implement the service. Okay, we heard from a small but meaningful number of folks with lived experience and providers that again, and I think this is, again, a kind of an education, relatively light lift recommendation, but important, that some providers in the primary care space or in the physical health care space may lack information about medication-assisted treatment. For example, a provider shared an instance of a doctor in Forsyth County recommending that they go off of medication-assisted treatment when they were pregnant. Which is counter to the clinical guidance for medication-assisted treatment in pregnancy. So we have a recommendation to see about looking at opportunities for providing some education and ongoing learning for physical health providers to have competency in medication-assisted treatment. We noted that with the LGBTQ community, there is right now, amongst several members of the community, a lot of fear around being able to be matched with a mental health provider or a substance use provider who understands the needs and the culture of the LGBTQ plus community. This is an area where there are already some partnerships that I think are strong and could be stronger between the county and LGBTQ plus advocacy community to just help get the word out, to help provide information about mental health and substance use within this community. We know from statistics nationwide that this is a community that experiences very elevated rates of suicide, elevated rates of substance use, and mental health problems. So we are recommending that the county strengthen partnerships with this community to kind of continue to develop awareness of services that are culturally responsive. Our final recommendation in this first tier is related to collaboration and coordination. So as I mentioned, the signature strength of this community is that there are a lot of passionate, experienced, skilled providers and coalitions and groups that are very passionate about meeting the needs of the community. However, in the report, we have sort of a list of groups that meet regularly to coordinate care or to coordinate efforts, and it's a very long list. And we heard in interviews that a lot of people feel overwhelmed by the number of coalitions and meetings that they go to, and some of the meetings seem to be focused on really similar topics. So we're suggesting here that Forsyth County may be able to kind of look across the different groups that are meeting, and almost always the county is at the table in these groups, and really think about what is the distinct purpose of each of these groups. Are there opportunities for alignment? Are there opportunities for streamlining? And are there ways to ensure that all of the groups are action focused? So that's our final. So not meeting just to meet, but really meeting for a coordinated purpose with action. So those are our tier 1 recommendations. I'll speed up just a little bit so we can keep within our time. As I mentioned, our tier 2 recommendations, these are not things that the county can do independently. They would require some local partnerships. Our first is related to employment. The graph at the bottom shows, again, just within the Partners Managed Medicaid group, people who were provided with supported employment services, with people with intellectual disability and people with mental health diagnoses. The numbers are in the tens, so relatively small numbers of people are receiving employment support services through Medicaid. They may also be receiving services through other entities, including the Department of Employment and Independence for People with Disability, which is the local vocational rehabilitation agency. But regardless, we heard in interviews, especially with people with lived experience, both with intellectual disability, mental health, and substance use problems, that folks want to work. And they feel that having a job is integral to their recovery and well-being. That resonates with me. Without my job, I think I would be a wreck, and I think other people may feel the same way. Others may be ready to retire, but I think a lot of people, work is a really important part of who they are. And so we know nationwide that people with disabilities want to work and that many are not working. So we do recommend, and that the number 1 social determinant related need is employment, and that's something that was locally determined here in Forsyth County. So we recommend partnerships to increase opportunities for supported employment services, and that would need to be, again, partnership with providers. The county could play a convening role, a supportive role, and also with the Department of Employment and Independence for People with Disabilities, which has regional offices nearby. Our second recommendation is something we heard very loud and clear from folks with lived experience that we met with, was that they don't participate in we spoke with a handful of people who are not currently in treatment, and all of them said that the reason that they do not participate in treatment is because the requirements are too high, namely going to receive outpatient counseling services during the day on a fairly intensive schedule in order to be eligible to receive medication-assisted treatment. That is one model of medication-assisted treatment that works extremely well for some people and is highly valued and works very well and very strong in this community. However, it seems that there's a gap for people who are earlier in the recovery process to get access to that medication-assisted treatment so that they can get a foothold in their recovery and then move forward. And in fact, the Substance Abuse and Mental Health Services Administration in 2024 issued guidance to this effect, that it is important to offer an array of substance use treatment services involving medication-assisted treatment, some of which are lower barrier and do not contain adherence to strict adherence to, daily or several times weekly outpatient therapy. It is still very important to monitor for safety and all of these things, but we recommend, again, not led by the county, but in partnership with providers, looking to expand options for accessing medication-assisted treatment. Finally, we recommend establishing a process for initiating medication-assisted treatment for people in the Forsyth County Sheriff's Office Detention Center. At present, and this is wonderful, if a person is already on medication-assisted treatment and they are incarcerated in the jail, there is capacity for them to continue receiving their doses while they're in jail. And a good number of people are receiving that, which is excellent. However, when a person is in jail, that's an opportunity to initiate treatment. It's sort of a window that can be very important. And at present, there isn't any process for people to initiate medication-assisted treatment while in jail. So we recommend a partnership there. We also recommend incorporating peer roles across the crisis service continuum. Right now, those roles are quite limited, and a best practice is to have peer support available to people in crisis. My understanding is that the new facility-based crisis center will have peer support, which is fantastic. We recommend exploring options to incorporate peer support into other mobile crisis teams and other teams that are going out in the community. As I mentioned, there are over 800 people in Forsyth County on the Innovations waiver wait list, which is a home and a pretty robust package of home and community-based services for people with intellectual and developmental disability. The average wait time on that list is almost 8 years, and 2/3 of those 800 families, individuals and families on that wait list are not receiving any services, any Medicaid services now. So we recommend that the county see if there are additional ways that they can benefit from increased information to access services that already may be available, going back to recommendation 1.1, and what those support needs are, to see if there are other ways that those families can get some support while they're waiting.
I'll stop for 1 second. It seems like at the last meeting, we had an update from partners, and that's our Medicaid assistance, our Medicaid folks through the LME MCO. And so I think one of those statistics was reporting the percent of people on the innovation waivers who were in fact receiving Medicaid, funded services. And I think that number, that's something they track. I think it was like 36%, and which that's not great, but it's not. But it probably doesn't fit into. Well, you did say two-thirds on the wait list are not. Well, that's about pretty accurate.
Yeah.
A little lower, a little over 1/3 are.
Yes.
I guess I heard you that there weren't many,
Yeah.
receiving it, and at least it is 1/3. You do talk a little faster than maybe it's my age. Maybe it's my age, but you.
No, it was glass half full,
You do
glass
speak
half
pretty
empty.
rapidly for me.
Yes,
Let's
yes.
put it that way.
Apologies. I will. I'll try to get slower. But yes, same. Yes, it is good, and it is. The 36% getting services is incredibly important. And then what about the remaining 64%?
I got it.
All right, couple more. The county has some excellent, valued workforce development initiatives that were spoken of very highly. There's a partnership with Forsyth Tech to provide support for people to receive training in social work, and there's been a good peer support partnership. We recommend that those continue and perhaps expand because workforce is like the number one issue that is challenging community behavioral health organizations, not just in Forsyth County. And something to highlight is, if you look at the population of Forsyth County in this graph here, the top line is the non-Hispanic white growth of the population, which is growing about 5%. Is projected to grow about 5% in the next 25 years. The non-Hispanic white population is expected to grow by almost 40%, and the Hispanic, non-Hispanic, non-white, so people of color, and the Hispanic population is expected to grow by 50%. So the need for bilingual, bicultural providers in particular is already high, and it's going to be higher, particularly in light of some of the disparities we discussed earlier with the Black community, maybe not seeing themselves in the provider community and that potentially being a barrier to treatment. So we strongly recommend that the county continue on this path of creating workforce development opportunities, particularly for communities of color in Forsyth County. And finally, the last recommendation in this tier is, you'll notice loud and clear in this report that most of the data that we have is for the Medicaid population. And while Medicaid serves some of our most vulnerable community members in Forsyth County, the majority of people are receiving their health care through other payer sources, including private insurance, Medicare, veterans, health benefits, et cetera. And we really don't have the same kinds of data for those populations. But we want to take a population health, this is the health department, we want to take a population health view of the community. So are there ways to develop some data use agreement with other health systems, with other payers, to start to develop an even more holistic view of the needs of the community? So we recommend that. We also recommend really identifying some specific system metrics. There may be metrics that you find particularly valuable in this report or others, and really pick those metrics and commit to looking at those on a regular basis over time to see if improvements that are put in place are working, to continue to monitor the functioning of the system over time. I have three tier 3 recommendations, and I'll wrap up. These are bigger, broader, thornier issues that the county could be a partner in, but wouldn't be resourced or wouldn't be appropriate for them to lead. The first is probably the number one challenge that came up across all of our interviews, focus groups, and listening sessions, is that people struggle to access ongoing outpatient treatment that meets their needs. This likely explains those elevated rates of emergency department visits, because people kind of wait till a problem gets to a crisis point and then they don't know where else to go. So we recommend, really the community coming together to expand navigation support, particularly for people with complex needs, to look at ways to expand access to same-day treatment, not just same-day assessment, but same-day treatment, awareness of services. And this problem is particularly pronounced for youth, which is hard. And again, not unique to the county, but something that will be very important to be tracking and working on in the coming years. Our second big picture recommendation is, in this community, there are a lot of different mobile crisis teams. There are 2 mobile crisis management teams. There's the BEAR team, which is operated by the city, and Mobile Integrated Health, which is operated through the county. There may be ways to create a more streamlined system between those crisis service providers, and also particularly for those providers to come together to see how better to support children and youth in crisis. Just looking at the mobile crisis management data, a very small number of youth relative to adults receive crisis services. There are relatively fewer options for children and youth in crisis. So we recommend some big picture planning and looking for opportunities to streamline and enhance those services. And finally, a major pain point As I mentioned at the beginning of this presentation, is people with co-occurring mental health and intellectual developmental disability-related needs. Supporting folks requires a specific kind of provider competency. Often folks with co-occurring mental health and IDD problems have very complex needs. They are often the people that are showing up again and again in the emergency department, that are in the emergency department with nowhere to go, needing a higher level of care. And so we recommend first a closer monitoring of kind of where is this population, what services are they accessing, where are the gaps, and then looking at expanding provider competency to support this population across the system. So that is everything that I have. I'm happy to take questions on the methodology or on the findings.
Well, thank you. Thank you very much, by the way. And I think you were kind of my observation that you, as a good consultant, you were very kind and complimented a number of good things, and clearly we have some. But my kind of read, I did give a quick read yesterday, and then a little more listening to today. I mean, there's some pretty serious problems that, in one sense, are fairly solvable. But well, I don't want to be too exaggerate that, but I mean, but they're serious problems. And I appreciate your the way you presented it from a good consultant public presentation summary, but haven't read your full, maybe a little more detail in your full study, but there's some good directions for where we need to go. And the question kind of becomes, I think, from our staff is, do we need somebody to help us with that or not, I guess, is a question. And I think that's something we need to give some serious thought to. But others that may want to comment, please do.
Dr. Croft, thank you for that presentation. I appreciate that. I assume you're not related to the Tomb Raider.
I am not. I've gotten that before, and I am not.
And I recall, it's been a while, but I did attend one of the listening sessions,
Yes.
and I was impressed with the presentation you all made, but I was also impressed with the feedback you got from the group that was there. I thought it was very good. I think I have maybe a basic knowledge about what's going on in the county here with regard to behavioral health, but I would be interested in your broader perspective. I'll give you an example. We've got vape shops all over this county that are selling kratom, and we had a bill to take care of that, which didn't pass this time around in our General Assembly, much to my regret. I don't know what the experience is in Massachusetts, but that is readily available. We've got all these new opioids. Fentanyl is old hat now. They're into xylazines, carfentanil, nitazines, and one that I can't pronounce because it has 5 or 6 syllables in it.
And they keep making up new ones every day.
Yes, exactly. What is your experience with regard to those, and any special recommendations you have above and beyond what you've already provided would be appreciated.
Yeah. It's really scary how quickly these synthetic opioids are being manufactured and how deadly they are. It just seems to be growing exponentially. The data are very clear, particularly at the local level. There's supply side and demand side strategies, right? Supply side would be keeping that stuff out of your community. Demand side would be providing support so people don't want it. The data are pretty clear that we have a lot of effective demand side. Well, first of all, supply side. I mean, there is law enforcement, and that's not my area. But a lot of that is also outside of the county. You can bring anything into the county, and there's nothing anybody can do about it. But on the demand side, there are a lot of strategies that work that are already working here in the community. That need to continue and need to be sustained. We know that distributing Narcan is effective. We know that distributing test strips are effective. I hope that more test strips are responsive to the synthetics, and but really getting that evidence-based support to people right away, and then decreasing the barriers to people getting help, creating as many pathways into treatment as you possibly can. is probably the single most important thing that I would recommend. So that recommendation related to opening up opportunities for lower barrier access to medication-assisted treatment, initiation in the jail, and more flexible options for people whose lives are too chaotic to show up for an outpatient appointment 3 times a week. Those would be kind of the top recommendations that I would have, in addition to continuing what you're already doing with the harm reduction piece.
Yeah. So interdiction if it's available, but once it's here, then certainly, and I saw that you had met with the Harm Reduction Collective.
Yes.
You're fully supportive of that approach, needle exchange, test strips.
Absolutely.
Whatever it takes.
People don't want to be high all the time. You know, most people want to get clean and get a job and get on with their lives. But addiction is a very serious disease, and they need a lot of help.
Yeah. Thank you.
Mm-hmm.
I do have maybe one question and just a comment around the focus groups that you all were able to engage. So I thought it was interesting in the Tier 2 recommendation, 2.1, I think it's page 28 of 58, to increase employment opportunities through expanded supported employment services and local partnerships. What does that look like real time for a county?
Mm-hmm.
Like,
Yeah.
well, how do we increase employment opportunities? Is that through our Community and Economic Development Department, and that's something that they need to focus on in collaboration with this? What does that look like?
Yeah, a couple things. I'll name 3 things. First, really sitting down with the Department of Employment Independence for people with disabilities and saying, hey, how many folks with mental health and substance use problems are you supporting? What are the barriers to your programming reaching this population? Like, what kinds of things could we be doing in partnership with you to get more people in the door, to get your vocational rehabilitation services, to get your employment? It's really interesting. We work with states and counties around the country, and some vocational rehabilitation agencies are really good at supporting people with mental health and substance use related problems, and some never support anybody. We didn't hear a single informant for this study reference this agency in our study, which is, I do not know how many folks they're serving, but I do know that there's probably untapped partnership and engagement. So that's the first thing. The second thing is there's all kinds of wonderful resources and work to create recovery-ready employers. So are there opportunities to work with local employers to educate them about mental health and substance use problems, to help understand that working with somebody with an addiction or in recovery, ways to kind of support them and employ them so it's not as scary to hire somebody in recovery, to kind of open up employment opportunities. And then the third piece would be, are there ways to expand evidence-based employment support services in the community? So individualized placement and support is a very robust model for supported employment. Are there ways to grow that service here in the county? And that would be a conversation with payers and providers, a little more complex, but another area that's important.
Seems like that would fit with that last, I'm sort of thinking what fits in the opioid settlement fund use.
Sure.
And if that fits, that's, because I see, that third one is an expensive one.
Yep.
And it would seem to me that, not that we have more money, but we do have some money.
Yeah.
And I think we operate with grants where we get proposals. And so we need somebody, applying for that can execute it and hire people and do it. And then I think that would bubble up to be a high priority, grant for us. And that isn't, I see that being, all 3 of the things you mentioned are effective. But that one is expensive, but it also, you have somebody that's kind of shepherding that employment and developing a personal relationship versus the more of a shotgun approach.
Yep.
I think that obviously with the funding for what Chair Martin is referencing is limited to dealing with the drug epidemic versus just comprehensively all of the grants that come in. It'll have to go specifically to that cause. And so I think that instead of having to compete with, as we think about our community grants, if we stay on that path, but as those, applications come in, instead of having those organizations that's interested in dealing with, this epidemic around, drug addiction and abuse, then they don't have to compete with that in that broad category. What can we do to streamline it so that we know that they are asking for funds so that, one, they could support employment of those that are trying to be rehabilitated and come back into employment spaces, what I would think would be more reasonable. But the last piece is the 2.2, which goes to my also connection to the groups that you all worked with in order to get some of your insight that's going on here in Forsyth County. So the quote is, they gave me what is that?
Suboxone.
I'm glad I don't know what it is to some degree. Repeat that again.
Suboxone?
But Suboxone, okay. They gave me Suboxone, and it didn't really do anything for me. Methadone would do it for me, but too many requirements. What are the requirements?
So the requirements involve participating in outpatient substance use counseling, individual and groups, kind of going into a clinic and participating in appointments. I don't have the exact requirements in front of me, but several times per week. And those appointments are typically held during the business day. So if a person is working, it's going to be difficult to have a 9-to-5 job, and also be participating in those groups. So those are the requirements that are, and then there's, I believe that those are the requirements that this person was referencing.
Okay, so then that's probably one of the main reasons why maybe you see that high disparity with African Americans receiving treatment, because of this requirement that has become obviously a barrier, I would assume.
It could be. I think that would be an important question to ask.
So is that something that's regulated obviously by our state, and is nothing that at the county level we can do to decrease those requirements?
There are service definitions that providers have to meet the components of, so there may be some opportunity for advocacy around clinical service definition changes that would promote easier access.
Oh, okay.
And in the report, we reference a resource from SAMHSA, the Federal Substance Abuse and Mental Health Services Administration, that actually is really on this very topic and lays out some best practices for lower barrier treatment.
Okay. And so then lastly, I would say that I think when I looked at the focus groups, I realized that you had, a great range of, I think, groups that are committed to improving this situation. I saw that you had the Latino Coalition. I think maybe I saw something with the transgender group. Maybe I didn't see anything specific to African Americans in this community, and as I thought about it, I couldn't even think other than one of our political groups versus any kind of coalition of groups that bring African Americans and our concerns in this community, and that may have been one of the reasons why they were not involved in a focus group, because you couldn't find a coalition of African Americans. The only thing I can think of again is the ministers' conference that have quite a bit of our African American pastors. But I think that's a challenge and something that, as we think about continuing to do research, I think that subgroup is very important to the focus group in light of what we see specifically affecting African Americans in this community.
Absolutely, that makes good sense. A leader in the ministers' conference did participate in this study and was able to give us some really important feedback. But you're right, there wasn't a ready group like the Latino Coalition for us to go and meet with. Otherwise, we would have. We absolutely seek out those groups in any jurisdiction that we go to. So yeah, I mean, that could be something that's needed, or maybe something that the ministers' conference would be interested in putting together.
I hate to admit this, but I'm not familiar with the Forsyth County Latino Coalition, and I am familiar with a number of the groups that do work in that space.
Yeah. Does anybody, I can share what I know.
I suspect there are references to
Yes. I'm
IAF.
sorry.
or Forsyth Strong.
Forsyth Strong. Oh, yeah, we know about that.
I'm familiar with it by another name, so.
I had one more question, because you made a remark about something that was disturbing, that pregnant women are being advised if they have substance use disorder just to stop taking it. Yeah. And I know that there is a facility, a nonprofit, I've visited it, I don't recall the name off the top, but they are working, I don't think it's open yet, to provide a facility that will house pregnant women with that condition for treatment purposes. I assume you think that's a beneficial resource.
Absolutely. Substance use treatment for pregnant and parenting women is critical. And we did note in the report that I believe there's a facility that is just opening. Yeah, and that's incredibly important. And you know, I don't know how widespread the misinformation is. I just know that we heard from enough people for it to be something we recommend the county look into around a need for education. Absolutely.
You know, the other thing about this report as we were working through the process is it is a point in time.
Yeah.
And there was a lot that was continuing to happen even as Bevan's work was being done. And I'd be, but what about this and what about that? And we're doing this, but it's a point in time, right? And at some point you have to put a pause button and assess what you have there. But the work didn't stop at that point. So you may be thinking the same things, but like I thought I've heard about such and such. Just know a point in time, and we probably should have made that clarification for you.
Yeah, I mean, the county, our assessment is that the county is moving in a positive direction. And almost all of the recommendations and ideas in this report are not coming just from us. I mean, they're things that people in the community want and know are needed because there's a ton of expertise right here in the county. A lot of my job is to just kind of like harvest all of those ideas and package them together for you in a report with some data.
Any other questions? Well, this has been an excellent presentation.
Thank you very much.
Appreciate you being here, and might hear more from us in the future. So,
Thank you.
thank you. Oh, I got an immediate request for a short break while we set up and transition to item 2, which is our own Attorney Gordon Watkins talking about our legislative update and legislative goals for the North Carolina Association of County Commissioners. Good, thank you. in that, so I'm guilty too. In any case, we're glad to have our attorney, Gordon Watkins, here, county attorney. This is an interesting presentation. Looking forward to the discussion. The floor is yours, I believe.
Thank you, Commissioners. I was going to say a comment about the behavioral health people, but they all left. So I will just say that, I've worked on opioid litigation and issues for many years, so it's gratifying to see the programs that we are running. What I'm here today to talk about is the 2026 legislative update, and then that will roll into the 2027-28 NCACC proposed legislative goals. That seems kind of crazy to be talking about 27-28. What I mean by that is the 2-year state budgetary biennial that starts with the 27 budget. The long session is in 2027. The short session will be in 2028. And at the end, I'll go through the timetable for the goal setting for that. Legislative update these days is really like the old saying about trying to drink from a fire hose. It's just way too much has been coming out, but I'll try to touch on some of the highlights here. So federal updates, of course, we know about H.R. 1, last year's big, beautiful bill. It's continuing to hit home to us. Two of the main features that you've heard about already. SNAP is the first one, October 2026. That's coming up in a couple months, where the county share of administrative costs will go up from 50 to 75%. The manager and others have already spoken to you about the impact that's going to have on us. The following year, October 1st, 2027, is when the error rate repayment kicks in. So if North Carolina has a large error rate, the counties, because in North Carolina it's a county-based system, the counties will have to pay that back to the federal government. And that's already been part of the state budget, whereby they will withhold sales tax from the counties to make up for this error rate. Again, that kicks in October 1st, 2027.
Hate to interrupt, but this early, is there any mechanism in the bill for proportioning the county charges according to the county performance?
The short answer is I don't know exactly how it's going to work, but it appears that the money will be borne by the counties. When we were speaking to Representative Lambeth in Raleigh for the legislative day, he was talking about, they may not audit all counties, they may audit, say, 10 counties. And so presumably all counties will pay if there's an error, but if the state focuses on those 10, that would be, I don't know, if it's us, that could be a lot. So I'm not sure exactly how they're going to work that out. And again, we still have more than a year to figure that out, but there is a mechanism that's alluded to in the budget.
Are we tracking county error rate?
Yes.
I believe we are, and I'll defer to someone who knows more about that than I do.
So I'm assuming that there would be data available if the state is in a position to do so, to apportion extra cost according to the error rates by county, so that there is a reward in addition to a stick for counties to keep their error rate down.
Absolutely, potentially. The state is determined to be at certain thresholds based on the collective of how all counties perform. So you may have 98 counties who are below 6% and 2% who are so far above that it throws the state at a higher proportion. So, but yes, potentially they could give a proportionate disincentive for higher error rates to counties if that's how they choose to roll this out.
Okay. All right. Thank you.
But did not our last error rate for us improve a significant amount?
Absolutely, in the state as well. So there's lots of work that is happening to try to reduce error rates. And I mean, I guess the ultimate goal would be that we would all be collectively performing at a lower rate, but we are not below the 6% at this point.
the mechanism that was approved takes a certain amount from all counties, and then there's a variable amount from other counties. I'm not quite sure how that variable amount works, but if there is a statewide error rate that's above the federal minimum or federal maximum, then we would lose money no matter what, even if we did a great job. That's my understanding. There also, as you know, there's some cost shifting on Medicaid. December 31st of this year is when the work requirements kick in. Those will have to be, there will be increased monitoring by county staff for that. And January 1st, the next day, is when the 6-month eligibility redeterminations begin. So again, that's more work for county employees. So there has been proposed, OMB, Office of Management and Budget, they've proposed a uniform guidance rewrite. And they would change it from guidance to regulation, which would be more enforceable. And what it also means is that OMB would really be in control of uniform regulation, they call it. I'll just say uniform guidance. They would be in charge of it, not various federal agencies. So it would all fall under OMB. The document they put out is a 415-page document and has all sorts of language about leftists and neo-Marxists and things like that. But when you get down to the gist of it, there's some things that really stand out, and I'm just pointing out what's in here. I'm not trying to be partisan at all. All federal grants would need to be approved by a federal appointed official. So nothing could be done by your general bureaucrats who have civil service protection. The fear is that this would really slow grant approval and could introduce uncertainty. What this change is really trying to do is to make President Trump's executive orders from early 2025 have the force of law. And so part of that is that any grant, any federal grant could be suspended or terminated at any time if it violated a presidential policy. So it's not a law, it's not a regulation, it's a policy. This would give the president sole discretionary control over about $1.1 trillion in annual spending. There are many things in there, but part of what recipients of money would have to do would to ensure that the subrecipient doesn't have a bad reputation, whatever that means. And there are lots of newly poorly defined obligations. So it would make compliance very difficult and very risky, not only for us, but for everybody receiving federal money. So as you can imagine, if we receive a federal pot of money and we want to say, work on, say, the airport, we want to, build a new hangar or something like that, when we go out into the market, we would have to let contractors know, hey, at any time you could lose your money. So at any time the contract could stop. Kind of the impacts of that would be, well, the contractor, one, may not apply, or two, may say, I'm going to build a risk factor into this, I'm going to charge you more. So those are some of the things that could happen going forward with that. But before I move on, there's a deadline of this coming Monday, June 13th, to put in a comment. And so unless any of you disagree, I'm using the draft that NACO prepared, which is actually quite good, and filling in some county individual data about that, and I will submit that by Monday, unless there's, basically stating what I've stated today, that we would like, and that's one of the legislative goals, that we would like there to be clear, uniform guidance.
That sounds great to me, and I would point out that concerns need not be specific to a current president. That's an enormous amount of potentially abusive authority for any single.
I think that is an excellent point. When you say policy, I mean, a policy could change year to year. But certainly if a Democrat gets elected and takes office in 2029, then everything would change. And that would be that would be hard for projects because a Democrat may not like our airport terminal and they could just cancel it. So it's not, as you say, it's not really a Republican Democratic issue. Okay, moving on, property tax changes. So this is no surprise to any of you. The General Assembly has passed, and it does not require the governor to say anything about it, passed a proposed constitutional amendment about limiting the annual increase in local government's property tax levy. So this is the language here. The general language is what's already in there. What is added is the underscored part. And so at the end, the underscored part says, the General Assembly shall enact general laws limiting the amount by which the levy of taxes on property may increase, which may include exceptions. So it's not the tax rate, it's the levy, how much you raise. So they could say, you know, Forsyth County, you raised, I'll make up a number, you raised $300 million this year, you can only raise $305 million next year. I mean, they won't say that number, but they'll have some kind of formula that would add up to that. And we don't know what that is. And of course, this would have to be passed by the voters. But if the voters do pass this, the General Assembly will come back and will decide. It says they shall do it, so they're commanded to do it. They shall decide what sort of limit there should be on the levy of property taxes. So, you know, any limit on property tax levies should consider changing populations, inflation, state of the economy, bond issues, and costs pushed down to the counties by state and federal government. As you said, as you saw, it did include exceptions. So we would want those exceptions, if there is an exception, to be clearly defined. And you know, what popped to my head was a natural disaster like Helene, or if there's a severe depression or recession, that would be something you may want to consider. You may say, we don't want to close our public schools if the economy is bad. But if there's a flat limit that says, you know, 3% or 2% or whatever, then that could really cause us problems going forward. Some issues, obviously, last month, you as a board approved your budget, and you're required to do so by June 30th. You did it in early June. The General Assembly just signed the budget, you know, a year and a half later, whatever, in July. So a concern would be if they dawdle too much on this and, you know, June 29th say, okay, you can only raise levies 1%, and we've already prepared our budget. It makes it very difficult for us. So it's kind of a double-edged sword, I guess you could say. We don't want them to be too quick to pass something. You know, if the constitutional amendment passed, we don't want the General Assembly to be too quick that they pass a bad cap, but we don't want them to be too slow that you can't do your job in approving a budget. So that's a concern. And also, as you know, the General Assembly has passed a property tax revaluation moratorium for certain counties. They passed one, and then they just passed another one that took some counties out. But I believe Guilford and Davidson are still part of that moratorium, and that caused some troubles for them, and at least for Guilford, in coming up with their budget. You know, moratorium, I understand people get shocked when their tax bill goes up. Of course, the tax rate can come down, so just because property was revalued doesn't necessarily mean you're going to pay more taxes. But if you have a moratorium, it defeats the purpose of equitable valuation of property. So there's also a constitutional amendment on the North Carolina income tax rate. So I just looked for the past couple of years. 2 years ago, the tax rate, well, let's see, in 2025, last year the tax rate was 4.25%, I believe. This year it's 3.99%. The state income tax is 3.99%. And in the budget, it's going to be lowered next year, so 2027 will be 3.49%. This constitutional amendment would change the maximum tax rate from 7% to 3.5%. So it would be basically where the tax rate is for 2027, but the maximum rate would be below where the tax rate is actually now. So, again, that'll be before the voters to decide if they want to do that. Possibly if it's passed, it will definitely limit future revenues, which could include education. And again, we've been in a pretty good economic situation, but if there's a downturn, this could cause problems. They did, I believe, in the budget, slow down the automatic income tax decreases that they had before. So it will take longer to go down in the future. And there were charts showing that even with those automatic decreases in the North Carolina income tax, there would be a deficit, a big, big deficit in a couple of years. So they're trying to address that at the state level. And of course, if there's limited state money, that can encourage the General Assembly to push more obligations down to local governments. This was a shock to me, and I don't know whether this had been talked about or not. We spoke to legislators, and I never heard anything about this until the budget came out. But minority and women business enterprises, also known as historically underutilized businesses, those goals and requirements are gone. They're just gone. They've been wiped out. So those statutes have all been repealed. Someone's gone through and taken out the language of every statute that applied to. The county may no longer, effective immediately, the county may no longer set goals for minority or women-owned businesses or require providers to seek MWBE bidders. And we've already spoken with purchasing, and they're aware of that, and they're making those changes. So that's already gone into effect. Diversity, equity, and inclusion efforts are forbidden. They passed all three bills. The last one is still pending. It was vetoed by the governor. It's pending. But the first one deals with DEI in higher education. The second one deals with DEI in K through 12 education. It also bans divisive concepts. So there's a whole list of divisive concepts that people aren't supposed to talk about. Basically the history, the United States being a racist country or things like that. You're not supposed to say that anymore. The last one would apply directly to state agencies and local government. It doesn't have the divisive concepts, but it defines diversity, equity, and inclusion as any program, policy, or initiative or activity designed or implemented to influence state government practices with respect to race, sex, color, ethnicity, nationality, country of origin, or sexual orientation, and then or to promote differential treatment or providing special benefits to individuals on the basis of race, sex, color, ethnicity, nationality, color of origin, or sexual orientation, or a difference in policy related to a protected characteristic. We're going to have to see how that plays out and what that means. That could, if that's, and again, that has not become law yet, but if that is taken literally, it could have some strong impact. Later on, it says we don't mean to interfere with the First Amendment, so I'm not sure how those are going to come together. But what it says is if this becomes law, it will take effect July 1st, 2027, and the counties will have to annually report to the state auditor on steps we've taken to eradicate DEI. Any violation of this could result in a civil fine or removal from office. There are a number of issues that have gone into law regarding your authority to have land use decisions, planning, zoning, development. The first one is 160D-1403.1, which greatly expands the appeal rights of anyone who does not agree with the decision you make or decision of the Board of Adjustment or a decision of a zoning officer in the planning department. It expands the statute of limitations to 3 years, and it greatly expands the definitions. So, typically people are supposed to appeal within 30 days, but now it's 3 years. And if somebody is appealing an administrative decision, they can skip the Board of Adjustment, that's why it's there. But this would allow them to skip that and to go directly to Superior Court or federal court if they're alleging it's unconstitutional. It greatly expands standing to include organizations, so the Home Builders Association could bring a appeal rather than an actual builder. A concern is it could tie up almost any planning decision for years in court. And what I don't really understand is it seems like it could cut both ways. If you're a developer and you get a neighborhood approved and a neighborhood group sues you, they could tie you up. So to me, it's not as clear of a pro-business change as I think it was intended to be. There's also expanded rights to attorney's fees only if the local government loses. And again, there was no debate on this. There's no debate on the budget. So we had seen many of these items before, and the NCACC and other folks were pushing back on them, but this just appeared in the budget. I'm sorry, I went the wrong way. Yes, it would be. And I'm not sure exactly what I guess you'd have to allege that it, maybe diversity of citizenship or something like that, or federal U.S. constitutional. But I would presume most cases would be Superior Court.
Gordon, could you prepare a discussion for us on the grounds for overturning a decision? I mean, what are the substantive grounds that could be used to challenge? It's
very broad. When you start off reading it, it sounds like if it's just unconstitutional, but it basically says, the part I quoted here was a decision implementing a local land development regulation. Well, that could be almost anything.
Well, yeah, I mean, what they can challenge in theory is one thing. The grounds on which they could overturn a decision is what I'm looking for.
Yeah, and I could do that. We won't really know until some of these go to court, but it is greatly expanded from what it would have been before.
Best analysis available at this point, I think, would be helpful. Thank you.
What are the grounds?
Well, they don't state that, but what I presume it's somebody alleging it violates the U.S. Constitution. I don't know. I mean, most of these aren't federal cases, but it does say Superior or federal court in there. And again, well, not again, but all of these would have been better to be debated. We could have pointed out some of those things, and we did on some of them, but it just got, as they say, the two corner offices were putting this together, and these are the kind of things that got put in. This is another thing that is, Chris isn't here right now, but this is very worrying to me. There's a new section that says that upon a written request, the planning staff must provide a written determination as to how a development regulation applies to a particular set of facts. Once made, such a determination is binding on the county unless a board or court reverses the determination. So if somebody comes into the planning office and says, I want to put up 63 houses on this plot of land, and the initial person writes up something that says it's good, and then figures out that, needs to be rezoned or I made a mistake or something, that's irreversible unless it comes up to you or Board of Adjustment or a court that has the authority to overturn that. So it would leave us vulnerable to determinations made by somebody, maybe it's somebody who's inexperienced, maybe they didn't have enough information at the time. I'm sure planning staff will set up some kind of some kind of process so that not just anyone can issue these written determinations, but there's a lot of communication back and forth all the time between planning staff and developers. And so having this be binding is problematic. The state budget also provides a $1,750 bonus payable to local sworn law enforcement officers. It's funded by the state, and it says it's to be paid by the SBI. So that's just another thing that was in the budget. So, and there's a lot more, and other folks will be looking through the budget and looking through these session laws that are coming out almost every day now to summarize them. But I've prepared, with some help of the manager's office, some possible legislative goals for the NCACC Legislative Conference. These are statewide goals. They're not Forsyth County goals. And so if they would be approved by the NCACC, it would have to be something that would apply across the state. So the first, and many of these are pretty much the same as what we took to our legislators to the extent that we took statewide goals to them. The first one is about property tax. It would support legislation to preserve counties' ability to collect property taxes, recognizing increased demands on counties due to federal and state unfunded mandates, population growth, and inflation, and ensuring that any cap on property tax levies contains clearly defined exceptions in case of emergency or severe economic downturn. So that's kind of what I stated earlier. As you have I've given you each a copy of the North Carolina federal legislative goals front and back. So as you have a chance to look at them, you can obviously make whatever changes or add whatever goals you'd like. The second one is, this is a bill that we were able to get passed unanimously through the House, but the Senate has not taken it up. And so if they still don't take it up this session, a possible goal would be to support the passage of House Bill 1042 to clarify that the affordable housing property tax exemption should not allow property managers to use nonprofits without actual management authority as a shield for for-profit activities. We talked about that before. That's relating to the Blue Ridge case, where a lot of other counties have signed on for these really sham nonprofits who don't have any authority whatsoever, but they're being used by for-profits to get tax exemption on hundreds of millions of dollars of property value. The next one is about downzoning. We've been trying to get this reversed for a couple of years now, but this would support legislation to amend 160D-601D to allow local government-initiated downzoning that does not restrict existing legal uses of property. That's where, you know, we want to update our zoning. You know, we find something that's dangerous. The example I use is a fertilizer factory. We changed, you know, where a fertilizer factory can be located on a property. That would not be possible now because we would have to get every property owner with similar property across the county to agree to that. This would simply allow us to downzone, not taking away any existing uses that people complain. They're like, I'm grandfathered in, you're gonna take away my use, and we've never done that as a county, and so this would clarify that that's the purpose of that. The next one is, again, one of our goals that we've had is to provide funding to counties to cover the increased costs of the special assistant in-home and facility-based cash supplements, which is shared between the state and the counties, but is dramatically increased due to the state's lifting of the cap on the number of people receiving such services. So that's just an increased cost that the state has passed on to us. And the next two relate to SNAP and Medicaid. 5 is provide funding to counties to cover the increased costs shifted by the federal government directly to counties to administer the SNAP program and provide statewide support and funding to counties to lower payment error rates. 6 is provide funding to counties to cover counties' increased costs mandated by the federal government's requirements to redetermine Medicaid eligibility every 6 months and to enforce expanded work requirements. So those are both hoping that we can get the state to cover those unfunded mandates. As I said, they've decided not to do that so far, but I would think we'd want to keep pushing for that. 7 is the one we've had for a couple of years, is to support additional innovations waiver slots, so as to increase the number of individuals with intellectual and developmental disabilities receiving the necessary support and services to live in the least restrictive community-based setting, and to shorten the wait list for North Carolina innovation waiver services. And we heard that mentioned today regarding behavioral health. And 8 was brought up by HHS and Deputy Manager Price. It is to support legislation to amend the licensing standards for mental health residential treatment facilities serving children in foster care so that they conform with all applicable federal Title IV-E requirements in order to maximize available federal funding, preserve limited state resources, improve regulatory consistency across licensed child-serving facilities, and strengthen protections for children receiving residential behavioral health treatment. My understanding of that is that the state requirements don't align with the federal requirements, so we're losing possible federal funding, but Denise can jump in and correct me.
That is correct. Effective July the 1st, we can no longer draw down 4E funding for residential level 2, 3, and 4 placements, nor can we draw down funding for our employees who are working on placement in such facilities. And that is because the licensure requirements in the state of North Carolina allow individuals to work in those facilities prior to having results of fingerprinted background checks.
Okay, and moving on to the federal goals, these are similar to what we've had in the past. The first one is relating to the uniform guidance I discussed, and that would be to support uniform guidance measures that provide clear direction for the administration of federally funded grants and assurance that awarded grants will be honored by the federal government. By the time November comes, that may not be an issue anymore. I don't know, but I thought that would be a good, because that's very, very important to us. It's very important to the state also, actually. Number 2 and 3 we've had before. 2 is support measures to reduce the number of people with mental illness in county jails, and legislation that would allow individuals in custody to continue receiving Medicaid and other federal health benefits until they are convicted, sentenced, and incarcerated. And 3 is oppose unfunded mandates and changes in eligibility for federal programs that shift costs to counties.
Can I ask you one question, Gordon?
Yes, sir.
If we had some discussion on Monday with the detention center on the possibility of the ankle bracelets release kind of issues. So if that were being used and they're back out, out of the detention center, what happens if they're a Medicaid eligible person? If they're on an ankle bracelet, is NAFCARE is not taking care of them in the jail because they're not in the detention center. So could they go back to being eligible for Medicaid? And particularly if it were done on the front end, somebody is being, incarcerated. They've been arrested. They could actually go on for a nonviolent offense. I assume it could be possible for them to have an ankle bracelet instead of being detained in the jail until their trial, I suspect, or until their hearings or whatever. I'm just trying to get at, if we heard the number of potentially half of the 900 plus inmates could be on this ankle arrest, house arrest kind of deal, bracelet, thing. If that's the case, what is your opinion on what happened? Can they now be Medicaid eligible?
I've learned never to answer anything about Medicaid, but I will say what you're saying makes sense. I think the key may be the point you made about not ever going into the jail. I think once you go into the jail, that's going to trigger losing the Medicaid. If the custody is outside of the jail, I'm not sure if Medicaid considers that custody or not. It would make sense to me that they don't lose their Medicaid, but that's something we could certainly look into. There's, and we heard this, but there's such costs of having someone in the jail. and the medical costs are huge. And so if they're not in the jail, as you said, they're not subject to NAFCARE, and that would save us a lot of money. But, you know, right now, the strongest concern is just having space. We just, you know, we're running out of space. I mean, they can add a few beds to that number, but not very many.
Exactly. Interesting. Thank you.
So the next steps for this month, you know, these are just proposals. These are not anything you have to do. And so if you all could please take a look at these legislative goals and send any suggestions. If you have a suggested new goal or revisions, if you could send that to both the county manager and myself, we can, you know, try to consider that. The deadline to submit these is August 14th, and so the last meeting before that of you, the board, is August 13th. So obviously you can do this in any order you like, but August 13th would be your last opportunity to approve the legislative goals. They would then need to be submitted. After that, through October, the NCACC has various committees that review the goals, pull together goals from different counties, put them into categories, and then they propose them to be voted on at the NCACC Legislative Goals Conference, which will be November 19th to 20th. And again, these goals, even though we're in 2026, these are goals for next year, 2027, and the following year, 2028. And I'm happy to answer any questions you have. Obviously, you have some time to review these and make whatever comments you want to.
Are the statutes you cited, are they complete and verbatim? I'm just, like the one for a law enforcement officer getting a bonus, is that the whole statute verbatim?
That's not really a statute, that's just a section of the budget. There are many, you know, properly a budget should be about money, but there are a lot of statutes that are in the budget, which is very frustrating to us. But that is just a provision that says, it's 3 parts to it, but basically that's what it says. It's a one-time bonus, and it says it does not count towards your retirement or benefits or anything like that.
It's also, your summary says that's state funded.
It is, that's correct. It's, for some reason, they put it through the SBI.
Well, it's taxable, right?
It should be taxable, yes.
Okay, and it says, well, any sworn law enforcement officer, I mean, is that somebody who's part-time, full-time, armed, not armed?
Yeah, it's worse than that, really. It says anyone who was sworn as of June 30th, 2026. So it could be somebody who's no longer working.
Sworn for one day.
Well, as of that date, but yes, it could be one day, but yes. And I don't know, you know, we have our CFO here, so I don't know how that involves taxes and everything. It says the SBI is going to pay the money. Maybe they'll send a tranche of money to us.
I mean, that's my assumption. I reached out to our HR director yesterday, who's reached out to payroll. My assumption is they're going to send us the funds, because I can't imagine they have the ability to pay individual employees in counties, but who knows? So we're preparing. If once we get the money, we'll certainly know how to process payments. So, and I can't imagine we would not tax it. So we're working through that.
Yeah, so obviously there are issues like withholding taxes and all that, and so I'm sure it would work that way. But I mean, hopefully they'll get the numbers right. I mean, we'll have to collect the numbers and send that to whoever we send it to.
Any other questions for Gordon? Thank you for preparing that summary.
Thank you.
Of not so good news, actually.
Well, the teachers did get a raise, so you know that's what we hear about a lot. So there was a little bit of good news, but there's some other news too.
All right, we're done.
Mr. Chair, no.
Oh, there's one thing, yes.
One more thing. The chairman and myself received an email this week from Chantel, And staff needs some guidance on the swearing in of Chris Parker to take the seat from Commissioner
Take my seat.
Take your seat. And we have two choices, and they need guidance from all of the commissioners to know what to do. One choice would be August 10th, and that's the same day of our briefing. The other choice would be to have a special committee meeting August 3rd. And that would have to, and that would just be a special meeting just for swearing in. So we need your input on which one you prefer. Or if you don't have a preference, we'll make the decision for you.
August 3rd?
Pardon?
August 3rd?
August 3rd. Richard?
I don't personally have a conflict that day.
Okay.
Up to y'all.
I don't. I don't have a conflict that day.
I did ask Commissioner Woodbury before she left, and she said she can make herself available on August 3rd as well.
Okay. Mm-hmm. You okay with that? Okay.
Okay, this is just a special
A
deal.
special meeting.
He won't be sworn in at a regular meeting.
And do you prefer a regular meeting?
I think he should be sworn in at a regular meeting, yes.
Wish I hadn't asked.
Well, whatever it is, we have to call a special meeting regardless. So even if it's on August 10th, it's called a special meeting. And we would have two purposes. It would be for the swearing in and then also the election of the chair and vice chair.
Mr. Parker, are you available both days? Okay. Well, I think if I
Not
heard.
available.
No. I think that the majority is saying the 3rd.
Well, as far as a regular meeting, I don't have a problem with that. I don't,
I only indicated that I'm available if there's a reason why we should do it on the 10th. I have no problem with that either.
Okay, we will do the 10th. Thank you.
We're adjourned till 2 o'clock.